Yeah, once more, I thank you very much for having me here so early, particularly. Now, this is not loud enough? Oh, yeah. Oh, God. Is
Microphone, use the microphone.
There are two microphones on. I don't know how many more I could use, but maybe I should use my voice then. Yeah, they don't seem to work. Sorry. All right. In 1984, in April, the retrovirologist Robert Gallo from the National Institute of Health in Bethesda and the American Secretary of Health and Human Services, Margaret Heckler, announced jointly that the cause of AIDS had been found and that this cause was a retrovirus, which we all know by the name HIV, or human immunodeficiency virus. This announcement was made at a time when not a single study had been published in the literature, that is in the American literature, on HIV. It was the first example of what we would call now science by press release. The scientific community, the peers, had no way of judging the merits of Gallo's hypothesis when it was announced to the New York Times and essentially became overnight national dogma. The evidence that was cited in the New York Times in favor of this hypothesis was that Gallo and his collaborators had found antibody against this virus in 85% of the AIDS patients that they had looked at the time, which was a fairly small number. Although antibodies are naturally understood, or had been until that time, as a defense against the microbe, in fact the ultimate defense and the rejection of the microbe, protection against disease, these investigators hoped that, they said that in the New York Times article, that a vaccine would soon be found, they said at the latest within 2 years, that would protect against this deadly virus and thus eliminate AIDS. And that was, in a sense, a controversial statement because antibodies, as I said, until that time were actually known to be the only and the ultimate defense against the virus. All they ever found in AIDS patients were antibodies, yet they said they hoped to come up with a vaccine. In fact, they're saying the same thing right now, 10 years later. They hope to come up with a vaccine when everything they can ever detect in an AIDS patient with the so-called AIDS test is antibody against the virus. There's so little virus there that only antibody can be found, and the antibody does such a good job that there's no virus left over. Yet we are talking about developing a vaccine that eliminates the virus that isn't to be found at the first place. In the scientific papers that appeared a month later in Science in May 1984, Gallo explained his hypothesis. He said HIV is a cell-killing virus, a retrovirus, killing T cells. T cells is one of the two big legs of the immune system. There are T cells and B cells. Once the T cells are gone, the organism is no longer protected by an immune system and now susceptible to all sorts of infections. But even at the very beginning, they included in the long list of AIDS diseases, AIDS is an acronym. The S in the acronym stands for syndrome, a collection of by now 30 diseases, some of them totally unrelated to each other. For example, they included from the very beginning diseases that had nothing to do with immunodeficiency, such as Kaposi sarcoma, which was almost the hallmark of AIDS at the time, a cancer that has nothing to do with immune deficiency, lymphoma, dementia, or wasting disease. All of these have nothing to do with immune deficiency. So the definition then, let's see, can I operate the slides or you operate them? I forgot now how that works. Is there some instrument I could? No, you don't have to dim the lights. These are all black and whites. I just wonder whether I could move them or you move them. Okay. Oh, I see. It's here. All right, thanks. Okay, I move them. So the definition of AIDS then turns out, so this was the Science by press release, the press conference that started the virus dogma. In fact, it was a very political thing from the very beginning. It was at the time when Reagan wanted to be re-elected or needed to be re-elected, and the gays had for the first time been organized and raised their voices, something has to be done about AIDS. And Reagan hadn't said a word about it. He only probably talked to John Wayne about it at that time. And then, since John Wayne wouldn't come to Washington, he got Bob Gallo and Margaret Heckler, and they said, we got that thing under control, we shoot that straight, we make a vaccine in 2 years, it's all gone. Yeah, so Reagan was re-elected, the gays believed it, and Bob Gallo became famous. Now here's the definition of AIDS a la Gallo, or a la now Centers for Disease Control. You have AIDS when you have 1 out of now 30 different diseases in the presence of antibody against the virus. So if you have now tuberculosis, or had it in '84, and also antibody against HIV, you were an AIDS patient. In the absence of antibody against the virus, you were just a tuberculosis patient, just as it used to be 100 years ago when Robert Koch first discovered the cause of tuberculosis. Now, if you have dementia, that's another one of those 30 AIDS diseases in the presence of HIV, you're an AIDS patient. Every doctor is excited about you. You're going to be published in The Lancet, in Science, and in Nature. But if you have dementia without HIV, you are stupid and nobody's particularly excited about you. And I know this sounds funny, but this is the Centers for Disease Control. This is not my joke. No, this is it. This is the definition of AIDS. And I think it's good to keep that in mind, because we always sort of led to believe this is a new disease. The Centers of Disease Control, the official national registry of AIDS, does not claim that even one of the AIDS diseases is new. Nobody says that. It only sounds that way in the media, but it is not. These are all diseases in the presence of antibody against the virus. And if the antibody is there, then the virus had done it. So that's the definition. Now, because of the growing AIDS threat, AIDS was growing and the epidemic was threatening, the National Academy of Sciences and the Institute of Medicine in Washington called a committee, the Blue Ribbon Committee, together that was to confront the growing epidemic. Their book, which is even now the Bible on AIDS, is called Confronting AIDS, and the committee was chaired by nobody less than the famous Dr. David Baltimore, who used to be chairman, a leading retrovirologist who saw nothing, who liked nothing better than seeing a retrovirus finally becoming nationally or globally important, because we had been chasing retroviruses for 30 years as causes of cancer, and came home from that war empty-handed. We learned a lot about retroviruses, but we did not find a single virus that would cause cancer in humans. And all of us, Gallo, Baltimore, Duesberg, you name them, were all veterans in that war on cancer, looking for something better to do with our viruses and our knowledge on these viruses. And AIDS came along, and here everybody was happy and immediately agreed that got to be it. At least now we have a chance for clinical relevance at last. So the committee had decided in a fairly short time. You see the language, that bold print is a direct quote from the National Academy's book of the Confronting AIDS book, that the committee believes that the evidence that HIV causes AIDS is scientifically conclusive. The language belief used to be sort of reserved for weekend activities when the committee members went to their respective temples or churches, but what they did during the week used to be either proven or not proven, or scientifically conclusive or not, but not what they believed. That wasn't so relevant for what they were doing during from Monday to Friday until 5 p.m. But all of a sudden that became a way of, that's another new development with AIDS, that what you believe, or what the majority believes, that used to be sort of politics or religion, that became now science in this field. So the committee then really sealed Gallo's hypothesis into national dogma, and with it now currently $4 billion taxpayer dollars annually are going into the virus AIDS hypothesis. If you study AIDS, if you want to study the virus, or if you want to treat AIDS patients with ACT inhibiting the virus, then you are eligible to get some of those $4 billion. If you say we may be on the wrong track, the virus is not the cause, then you get nothing of those $4 billion. Now, the conclusion of the committee, however, was based not on scientific proof. It was based only on what you call now circumstantial evidence in the courts, or in the courts of science as well. The primary assumption of the committee was, and is now, the primary argument for the virus hypothesis is what they call a close to 100% correlation between AIDS and antibody against that virus. An antibody is already equated with the presence of the virus, although that is by no means so. As I pointed out to you, antibodies was, until Gallo, the counterindication for a virus. It was the body's defense against the virus. When the antibodies were there, the virus was usually no longer there or was about to disappear very soon. So the committee believed, and I'm quoting again from that book, Confronting AIDS, that close to 100% of all individuals were harboring the virus. But when you look even now, where is the evidence for that frequently cited statement that doesn't every AIDS patient have that virus? There is no national statistics anywhere in this country or anywhere in the world to document that important claim. It is true that the Centers for Disease Control publishes monthly statistics which is called the HIV/AIDS surveillance reports. Those are the national statistics. But HIV is only in that first line in the title. Everything from then on in the surveillance reports AIDS in New York, or in San Francisco, or in Chicago, or in gays, or in bisexuals, or in nuns, or in scientists, or in dentists, but he doesn't say one word more how many of these AIDS cases have HIV and how many don't. Nobody ever publishes that number. It is always assumed to be 100%, and it is based entirely on selected individual studies. The committee relied primarily on Gallo's numbers, which have been found after a 3-year investigation by the Office of Scientific Integrity to be fraudulent, and Gallo was cited for scientific misconduct for the very same studies that were the basis of the National Academy Committee to conclude that they believe the evidence is conclusive. So we have nowhere a statistic that in fact proves that all AIDS cases, or close to 100%, or even any number of them, is antibody positive. It is true that some of them are positive, probably more than 50%. But if you look for cytomegalovirus, or hepatitis virus, or Epstein-Barr virus, or gonococcus, or syphilis, or any other microbe, you'll find also that over 50% of the AIDS patients are positive for these microbes by virtue of so-called risk behavior. If you have sexual contacts with a lot of people, you pick those up. They're not all that harmful, by the way. Or if you're intravenous drug user, likewise, you pick up more microbe than the average citizen who has less than 1,000 dates per year, unfortunately. Yeah. So the basic assumption then that the correlation is 100% is in fact only based on very selective individual studies. There's no national statistics on that. The committee also believed, and I'm quoting, that the virus is not found in persons who are not at risk of infection. That's what they said in 86 and in 88. But in the meantime, the World Health Organization announces, and others, even the Centers for Disease Control, that there are 1 million Americans infected by HIV who are healthy and have been healthy since 1985, since the virus can be detected. There are now 8 million Africans HIV positive who are healthy. There are 500,000 Europeans, 1.5 million South Africans, 1.5 million Asians. Altogether, 13, 14 million people have HIV and are totally healthy right now on this planet. So the assumption of the committee that the virus is not found in persons who are not at risk of infection, what they meant, of course, at risk of getting AIDS, is by no means true. The committee also believed that AIDS is unknown in persons who are free of HIV. That, in turn, is also not true. There have been, even at that time, already quite a few cases of gays with pneumocystis pneumonia and Kaposi sarcoma, of intravenous drug users with tuberculosis and weight loss and dementia, and of babies with mental retardation. That is all AIDS cases by current definition in the absence of HIV. I have tabulated HIV-free AIDS cases that I could find in the literature because the CDC doesn't list them. Recently, well, you see, I'll show you the table in a minute. Apparently it's not in the right sequence. There are 4,621 such cases currently in the literature that I could come up with, HIV-free AIDS cases. The committee also accepted without questioning, that comes in a minute, I guess I should get this back in, so, but that comes in a minute. The committee also accepted without question the practice of the AIDS, the proponents of the virus hypothesis, to use antibodies as a measure of instead of the virus, and use antibodies as an indicator of pathogenic powers or disease powers of HIV currently acting or yet to come. But as I said, antibodies have always been considered ever since Edward Jenner invented vaccination as the opposite of this, and they had never explained why. And lastly, they accepted what we know now are uncontrolled studies that AIDS could be transmitted by transfusion. For example, that hemophiliacs or other recipients of transfusions would have gotten AIDS from a blood transfusion. But the evidence for this is all, again, uncontrolled evidence. It is true that a few hemophiliacs have developed pneumonia subsequent to a transfusion with HIV. But what they have never done in this $4 billion market is called a controlled study. What they should have done is take 100 hemophiliacs who are HIV positive owing to transfusions and compare them to 100 hemophiliacs who are matched for all other criteria, factor requirements, age, and so on, except that they do not have HIV, and then determine who gets more diseases or who gets sick and who doesn't get sick. That they have never done. But there are 18 or 20 smaller studies in the literature who have done exactly that, and they found there's absolutely no difference. That is, hemophiliacs with HIV and hemophiliacs without HIV have exactly the same morbidity and mortality when they compare to each other. The same thing is true for transfusion recipients. People who have received transfusions with and without HIV have exactly the same mortality and morbidity. But what they do is they selectively cite only those like Paul Gann who are HIV positive and see Paul Gann died with AIDS. What they don't tell you is that the man was 79 years old, had a 5-fold bypass operation, a 3-fold bypass operation 8 or 9 years earlier, and then fell in his home and busted his hip, was immobilized in the hospital in Los Angeles for 2 weeks and developed a pneumonia at 77 years of age, and then he was, of course, an AIDS patient. A controlled study would have looked at 10 Paul Ganns or 10 men of that age group who had bypass operations and broken hips and were hospitalized and immobilized for 2 weeks with HIV and without HIV, and determined how many of those developed pneumonia, whether those with HIV were dying from pneumonia, when the others were jogging on the beaches of Los Angeles. But that, as I said, was never done. So the committee had adopted the virus AIDS hypothesis on the basis of questionable assumption and circumstantial evidence. And to date, this virus hypothesis that essentially they have sealed into national dogma and the only approach to the AIDS crisis has been a complete failure in terms of public health benefits. The promised vaccine has yet to come. AIDS continues to spread. We have no effective prevention, despite condom and clean needle programs, and not even one single person has been cured or even helped in the name or on the basis of this virus hypothesis. On the contrary, I'll explain in a minute, we are in the process of helping 200,000 people to die from AIDS with ACT, a drug that is by far the most toxic drug that has ever been approved for long-term consumption. By comparison, Mercury is a picnic, I can tell you that only. AZT was designed to kill human cells 30 years ago for chemotherapy. Mercury is maybe toxic, but it's not designed to terminate DNA synthesis. That is given in the name of this hypothesis currently to 200,000 people on this planet. So the hypothesis has been, without any question, a complete failure so far in terms of public health benefits. Nothing has come out of it. Although the spending on it annually alone exceeds all spending combined against all viruses in history that we have known so far. But the acid test of a hypothesis in science is not necessarily to produce good results. Take, for example, the weather forecasting. You have a perfect theory on weather forecasting. You can predict exactly whether it's going to be sunny or rainy tomorrow. That's the hallmark of a good weather forecast hypothesis. But you cannot change it, at least not yet. You don't know how to make it rain tomorrow if it's sunny or the other way around. So that means if a theory can make correct predictions, even if it doesn't produce results, that is the acid test for it in science. Now, let's see, although it wouldn't hurt if a theory produces good results. Then you don't have to ask much further. But if it doesn't produce results, it's not automatically proved that it's a bad theory. What the acid test is can it make accurate predictions? And here are the predictions of the virus AIDS hypothesis. And let's have a look at them, what they have produced. It was predicted from the very beginning by Gallo, by Heckler, by Surgeon General Koop, and so, which are all essentially just microphones of the virus researchers, that AIDS would explode from the original risk groups into the general population. Heckler said at the time into the heterosexual population. That was politically not the correct language, and therefore she's now ambassador in Ireland. It was supposed to be sexually transmitted, an equilibrate between the sexes like all other venereal diseases, including babies. But here's what you see, what happened. In America, AIDS has remained to this date, and in Europe it's the same. In Africa it's different. I'll tell you in a minute why. In the same original risk groups. Male homosexuals still make up about 60% of all AIDS patients. Intravenous drug users, male and female, about 30% of all AIDS patients. And recipients of transfusions. Since 1981, AIDS has remained primarily a male disease. No other infectious disease, certainly no venereal disease, has ever remained 90% male for 10 years in a population of 250 million like in America. Here's another prediction that the virus hypothesis would make. It predicted that AIDS would spread following the dissemination of virus. So whereas the virus, there would be AIDS. And this would follow initially they said within a couple of months, like all other viral diseases, follow infection within a couple of months or weeks or days. And now they say within 10 years. But look what's happening. In America, we had a couple of hundred AIDS cases 10 years ago. Now we have about 50,000 cases a year. But ever since HIV can be detected, 1 million Americans are infected, no more and no less. That number hasn't changed one bit. That's in the first test in 1984, the last one in 1993. 1 million Americans are infected, despite or with and without safe sex, and no matter what you do, the number of American HIV-infected persons has not changed one bit. But AIDS has changed quite significantly from a few hundred cases now to 50,000 cases per year. Very poor correlation, in fact, no correlation whatsoever. The fact that the number of American HIV carriers has remained so consistently at 1 million has been discussed in an article in Spy magazine a couple of months ago under the title, "The Good News is that the bad news is the same." So they had called the Centers for Disease Control and asked them, is it still the same? And yes, they said they always said, oh, it's exploding, but it's exploding at 1 million. For 10 years, it's exploding at 1 million. It's very steadily exploding at 1 million, yeah. But AIDS, while AIDS is spreading, not quite exploding, but it's going up from a few hundred to now 50,000 cases per year. So that prediction didn't pan out so far. Another prediction was immediately made that healthcare workers, those essentially soldiers confronting AIDS in the front line, those who would treat the patients, would be the ones who would contract AIDS from their patients. They would, by treating them, by washing them, by surgerizing them, by pulling their cavities and all this, and or putting them in their coffins, they would get AIDS. And they also predicted that those courageous scientists like Bob Gallo and others who grew tons of HIV virus for the AIDS test and still growing them, and at good commercial benefits for them, that those heroes in the front line against the virus would immediately be subject. They would be dying like flies in their laboratories, rich but dead from the deadly virus. In reality, not even one of those, by now 10,000s of AIDS, courageous HIV researchers has ever contracted AIDS from growing HIV in his or her laboratories. And believe me, they grow virus at titers that have never been observed in AIDS patients. In AIDS patients, you'd be lucky if you find 1 infectious unit per milliliter. They grow it at 1 million infectious units per milliliter in their laboratory. In those laboratories, they might be operated at a very, very high level of security, but still it happens that some of them have babies with their collaborators, but nobody, and there are documented cases of nations leading AIDS researchers having babies in the same laboratory with their collaborators, but never ever did anybody get AIDS from the deadly virus yet. And that is in the absence of a vaccine and an antiviral drug. I mean, two heroes without any casualties. Another group that was predicted to fall victim of the deadly virus, spread sexually of course, would be the prostitutes, because it's their business to have sex with everybody who can pay for it, I assume, and still they wouldn't, not one of those got AIDS either, except when they were intravenous drug users. So in the whole scientific literature, there's not one case of a doctor in America who has contracted AIDS from his or her patients. And remember, this is supposed to be the infectious disease of the century. 250,000 patients have died now with AIDS in those hospitals, have been seen by doctors, by healthcare workers. Not one single case confirmed in the literature that a doctor ever got AIDS from his or her patients. That's indeed remarkable, considering that we have no vaccine and no antiviral drug. Imagine that Albert Camus, you know, the famous French writer who wrote the book The Plague about the cholera epidemic in North Africa 50 years ago, would have come to this country to write about the the most important plague about the millennium, that is AIDS, as an infectious disease. He would be now at page 1. There would be one sentence on that page. There's nothing there. I have to wait for my latent period or whatever it is. So no spread of AIDS, no, this prediction failed completely. Well, here's another prediction that failed miserably. It was predicted that when chimpanzees would be inoculated by HIV, provided, of course, they were susceptible to the virus, right, provided they were susceptible to the virus. Oh. Hello?
The feedback was coming from here.
All right. Okay.
Well, you just talk about it.
Yeah. So it was predicted that chimpanzees would when they were inoculated with HIV, that they would get HIV, AIDS of course, or that the 15,000 American hemophiliacs who were all infected by the doctors iatrogenically, that they would die off like mosquitoes. The streets would be littered with dead hemophiliacs by now. Now what has happened? The 150 chimpanzees inoculated with HIV are doing very well in their cages eating bananas. Not even one of them has died. They're all doing, and they're costing $50,000 a piece per year, more than 2 or 3 postdocs in Gallo's laboratory. And they're doing extremely well on HIV. They're making the same antibodies as the human cousins, and they do not get Kaposi sarcoma or dementia. And contrary to prediction, the median half-life of hemophiliacs in the last 10 or 15 years has doubled, since 75% of them, of 15,000 Americans, are on HIV, hemophiliacs, owing to transfusions. Now, you could make a logical argument here that HIV has doubled the life of hemophiliacs. I'm not insisting in this yet, but I mean, I like to consider it at least. The reality is, of course, the treatment of hemophilia has been improved with factor 8, and the factor 8 has been better purified, so their life expectancy has been increased. HIV is irrelevant to the morbidity or mortality of hemophiliacs as it is to everybody else. Another prediction that was made is that natural vaccines or artificial vaccines would protect against AIDS. Well, the reality is, as we already covered, antibody against the virus, which is a natural vaccine against the virus, that is so good that the virus is not to be found, is in fact the prediction or the predictor, as they say, for AIDS. Only when you have made this antibody and when it is almost impossible to find the virus, only then they say, can you get AIDS? Not if you failed to make the antibody and the virus titer would be high, that would be a logical situation where you could get a viral disease. But no, that's not what anybody says. Only when you get antibodies, then you can get the disease. And then they say, in addition, they want to make a vaccine. Well, how much better can they do than a natural vaccine that is so good that nobody can find the virus? So that's, I don't know what the logic of this is, but it's always said at the same time that the antibody is a deadly sign for disease, but we are making a vaccine against it. So, don't know how. Now, another prediction that was made that HIV, Gallo said that from the very beginning, would cause AIDS by killing T cells. Now, what Gallo didn't emphasize in that original paper, that in the same month as he published in Science that HIV would kill T cells, he signed under oath to the US Patent Office that he was the one who could cure HIV better than anybody else in the world. And guess where he was curing it into? Still patented, still going on, in human T cell lines. These are human T cells put in culture which now assume the property of curing indefinitely. These very same cells of Gallo are still curing in his laboratory, at Abbott Laboratory, DuPont Laboratory, many laboratories, and Gallo gets royalties and everyone else gets royalties for the 25 million AIDS tests that are conducted per year alone in this country and many more millions abroad. $50 a piece approximately. You can calculate, even if you get only 5 cents for every $50, you are not hurting. You can pay a lot of lawyers for that to continue your work. Or even scientists. But Gallo pays, I think at the moment, as much to lawyers as to scientists. But things are moving nicely for him. Anyway, so what I try to say is the HIV does not kill T cells in cell culture. In fact, these cells are growing indefinitely like all other retrovirus infected cells. The hallmark of a retrovirus is not to kill the cell. That's why we're chasing retroviruses in the last 20 to 30 years as possible carcinogens. Because a virus that would cause cancer would have to be a virus that doesn't kill a cell. If the virus kills a cell, it couldn't cause a cancer because there would be nothing there to go into the cancer. And that's exactly what HIV does as well. Even in primary cells, Montagnier has recently published and others, the T cells are not killed by HIV. So the prediction that it would kill the T cells, again, turned out to be wrong. Well, there are more predictions on the virus hypothesis that turned out to be wrong. One of them was that if HIV is really the cause of AIDS and the common denominator is an immune deficiency, then you would predict that all AIDS diseases would be immunodeficiency diseases. That is, microbial infections or viral infections because the immune system failed. But the reality is that about 39% of all AIDS diseases in this country last year had nothing to do with immunodeficiency. They were diseases that, maybe just have to check how this gun works, but anyway, well, I think this one. Okay, it doesn't matter. So they were diseases that had nothing to do with immune deficiency. For example, Kaposi sarcoma and lymphoma are cancers which are not a consequence of immune deficiency. Dementia has nothing to do with immune deficiency. You can be smart or stupid regardless of your immune system. And wasting disease, the AIDS wasting disease, is specifically designed as a disease that is not due to microbial infections. It's analogous to anorexia or to cachexia in cancer. That is a weight loss that is typically seen in junkies, by the way, and is not due to microbial or viral infection. 39% of the American AIDS diseases fit that category. That is, they have nothing to do with immune deficiency. Another prediction that was made is that AIDS would be restricted by restricting the spread of HIV with safe sex, with condoms, the usual things. And as we know, despite these wonderful programs, which is the only thing that the virus hypothesis claims on its merits, AIDS continues to spread. And here's the last one that I could list. AIDS would occur only in people infected with HIV. As I just pointed out, I have just published a paper in Biotechnology, the August issue. It's a Nature publication in which I listed HIV-free AIDS cases that I could find in the literature, and I came up with 4,621 HIV-free AIDS cases in the literature in studies that have used the AIDS test or other tests for HIV and have been unable to find HIV in 4,621 such cases in the literature. Here's roughly how they were broken down. Most of them, in fact, are in Africa, because Africa is the only unbiased country that does an unbiased AIDS diagnosis. It uses what's called the clinical diagnosis. It looks at the disease and says, yes, this guy has AIDS, and then they ask for HIV. Here we do it the other way around. We look for HIV, and then we look for disease, and then we call him an AIDS patient. Therefore, the correlations in America are close to 100%, because when it's HIV-free, they say it's called by the old name. It's no longer called an AIDS case. That way, you get 100% correlation. But in Africa, they can't afford the AIDS test because $50 is more than the annual AIDS budget for an African on average. So therefore, they rely on the old diagnosis, the clinical diagnosis. They diagnose dementia, tuberculosis, weight loss, fever, and diarrhea, and then occasionally test for HIV. And when they do that, half of them turn out to be negative. And that's probably the same number here, but we'll never learn about it because we don't have any national AIDS statistics. We have AIDS statistics, but no HIV statistics, as I pointed out. This is only based on private selected studies from Dr. Gallo or other laboratories. So the virus hypothesis has not made so far one single valid prediction, not even one. It has produced no results, and not even one prediction has been confirmed that this hypothesis has made. That is usually the end of a hypothesis in science, except, of course, if you get $4 billion for it. Then I would look for it, I would study it a little more carefully too, a couple of more years, every year. And it doesn't hurt to study it very slowly and very carefully for $4 billion. You know. So now, what could HIV be if it were not the cause of AIDS? And what could AIDS be? Well, HIV could be what most viruses are in their hosts, including viruses in humans, namely a passenger virus. A virus that is simply there for the ride without killing the host. The majority of the virus, believe it or not, are in fact not in freezers or in laboratories or in molecular clones, but they are in their hosts or hostesses respectively. That's where they have been in the last 3 billion years of life. And most of them have no interest whatsoever in killing their hosts or even making them sick. They try to keep them alive as long as they can live with them. It's a bit like a government taxing the host. You know, they take a minimum amount of taxes and keep the machine going, rather than like occasionally taking over completely and taxing them to death and causing a disease. So typically, most viruses do not cause a disease, but just hang around there and killing a few cells at a time, taking a few proteins and a few vitamins, whatever it takes to keep them alive without causing a disease. These are the passenger viruses. Now, how do you tell a passenger virus from one that is causing a disease, from a causative virus? These are the, let's see, I want to skip this one. Here are the criteria to distinguish, classical criteria to distinguish a causative virus, a virus that causes a disease, from one that is just hanging in there for the ride. And autonomous microbe, virus, typically bacteria and fungi also, they can be a little more different, cause a primary infection, or if they cause a disease very soon after infection, then immunity follows, and if the immune system works and the disease is resolved or rejected within days or weeks after that infection, and the virus is now eliminated, or else it could hang in there in the form of a latent virus, like herpes virus. If you had once a herpes infection, you'll have it for the rest of your life. Same with retrovirus, same with many other microbes. They hang in there. When the immune system fails at a later time, 10 years, 20 years later, they can start hitting again, like fever blisters and so. They become active again, they notice the immune system fails, and then they become active, and the immune system knocks them out again. So that the typical relation then between a causative autonomous viral pathogen and a host is that it initiates the disease within a short time, and then the immune system rejects it, or if the immune system fails, the host could die. So the process of pathogenesis is initiated and controlled by the virus. Like the virus is essentially the pilot of the event. But in the case of a passenger virus, the time of the primary infection and the disease with which it is connected, like, say, HIV and AIDS, are totally unrelated. The passenger virus could infect you today, and the disease could follow 30 years later. If Dr. Gallo or some other virologist now starts using the polymerase chain reaction in disease to look for, quote, a causative virus, he would find all sorts of passenger viruses that you have accumulated in the last 10, 20, or 30 years. So the telling difference is that the time of infection and the occurrence of the disease in a passenger virus are totally unrelated. The time of infection is irrelevant to the cause of the disease because the virus is irrelevant to the cause of the disease. You could be infected by a passenger virus today and get AIDS 10 years from now, and the passenger virus might still be around in a latent form, But since it hasn't caused AIDS, the time interval between infection and disease is unpredictable and irrelevant. With the causative virus, one follows the other very fast, like the pilot directing the flight of the plane. And the passenger can be sitting there for 10 years and the plane may not start. Another telling differences between the two, the causative virus is always present when the disease occurs, but the passenger may or may not be present because the flight goes with or without the passenger, but not without the pilot. So if you have poliomyelitis or you have tuberculosis, the tubercle bacillus is there or the poliovirus is there. That's in fact nothing else but restating Koch's postulate. In its absence, the disease wouldn't occur. But you can very well have AIDS without HIV. I just documented 4,621 such cases. They're exactly the same as those with HIV, indicating again that HIV may well be a passenger virus, not a cause. Now here's the third criterion. The causative virus gets the disease done because it does something for it. Like all of us, when we want to get something done, we have to do something for it. So the causative virus is maximally active and abundant during the course of the disease. Virus replicates, many viruses are around, they make DNA and RNA and protein, all the good things, and then the disease follows if they get enough cells infected and enough proteins and things made. So the disease is initiated and controlled by the action of the virus, again, like the pilot controls the flight of the plane. But the passenger virus can be anything it wants to be during the course of the disease. It can be active, benefiting sometimes or often from the immunodeficiency, which typically precedes or accompanies the disease. That also lets the passenger virus turns it loose a little more. But it could just as well remain latent because it isn't responsible for the disease. It could sleep in the back seat of the plane, or it may not be on the plane at all. And all of this is the situation for HIV and AIDS. I have here a graphic representation of this. On top, you see the relation between causative virus. This would be the microbe titer. That would be the disease here. The microbe titer is dark and the disease following very soon after. Say that's a herpes infection. That would be the causative virus. It could be syphilis. It could be flu. And so the virus becomes most active, and soon after the disease starts, this would be some arbitrary titer of disease, and then the virus becomes eliminated or it becomes neutralized and essentially restricted to latency. I chose this herpes. And then at unpredictable intervals, let's say 10 years later, you start menstruating, you get excited, or you get in the sun, and then you get fever blisters or herpes again. And here the virus becomes active, and soon after you have some symptoms again, and the battle starts all over. That's typical for causative virus. Here's the opportunist or the passenger virus. That's the real word for it. Infecting you today, nothing happens. Then 10 years later, you get AIDS, and Dr. Gallo looks for it, the virus, and finds the virus and sees, oh, the virus caused disease because I found it there. Yeah? What he doesn't say is in most cases he can't find it there. You still have the infection. 10 years later, you get AIDS. He can't find the virus. Then he gets it from Montagnier, from Paris in the mail. He still claims, oh, because I got it in the mailbox, the virus has caused it. And now Duesberg looks at some cases here. You have AIDS. The virus has never infected before and is not present now. You have HIV-free AIDS cases, still the same AIDS, no virus there. Well, they say, we don't call that AIDS anymore because there's no HIV. Fauci and the Centers for Disease Control got together last year after the Amsterdam meeting. In 2 weeks, they had a new name for HIV-free AIDS because that was even too threatening for them. They called it, it's hard to pronounce, idiopathic CD4 lymphocytopenia. With that great name, they succeeded brilliantly to keep it out of the press. No reporter has been able to memorize the name. You have never read any headlines on the 4,621 idiopathic CD4 lymphocytopenias occurring in homosexuals and in drug users anymore. They used to be called for a short time HIV-free AIDS cases, but now they are idiopathic CD4 lymphocytopenia and they're gone. So that was a great job of covering things up in a very short time. They flew over to Amsterdam in Air Force 2. They had to because there was this article in Newsweek last year by Corley, who thought it was great to write about that because some American researchers thought they had found a second AIDS virus. They called it HIV-free AIDS, and they claimed the second virus. Jeffrey Lawrence in at Columbia, or was it at Cornell University, and Gupta in Irvine, were some of those. And they thought that's a sensational study, and no AIDS virus found, wrote it up big in Newsweek, and the Europeans and non-Americans were stupid enough to believe now the Americans give the green light, you can report HIV-free AIDS cases. And they all said, oh, I have HIV-free AIDS too, HIV-free AIDS. The Americans let me say it now, I can say it, I get my grants. And Fauci and Curran were still at the NIH and at the CDC. And when they realized that's what's going to happen, there were hundreds of people raising there, the blood banks aren't safe, there's HIV-free AIDS. So they hopped immediately on Air Force 2 and flew over and did damage control. And 2 weeks later, they called a meeting in Atlanta, coined the new term, and invited Corley, the Newsweek writer. All of them were now back in the club again. Of course, Duesberg was not invited, and they all agreed, well, that's a totally different disease, has nothing to do with it. It's very different. The symptoms are so different. They're just the same 30-old diseases. And they did a beautiful job. Nobody reports about it anymore. A few cases again from Europe, but not from this country. People know them well. If you write about that too much, it doesn't help with your current application. Yes?
About enthusiastic report that finally live virus has been found in lymph nodes.
Life nights, yeah, that's an enthusiastic report by Anthony Fauci. Have you looked at the numbers in that report? There's a lot of enthusiasm. It's almost like, it's very Italian, like the opera. So. But if you look at the number of particles, as one virus particle in 1,000 infected cells, exactly the same that Gallo had found 10 years earlier. And the lymph nodes are the dustbin of the immune system. That's where again, he said, look, I looked finally at the lymph nodes. You know, where the virus was first found by Montagnier in the lymph nodes. That's why it was called, at that time, lymphadenopathy-associated virus. And there was 1 in 1,000 infected cells. And the virus was neutralized by antibodies. It wasn't infecting any other cells. Exactly the same with Fauci. He couldn't find infectious virus. He only found viral nucleic acid in there and had used the polymerase chain reaction. There was nothing new there. It was just the corresponding hype to cover up the failure of his disappointing results. He hoped to they use higher technology. That's all that has happened. We have technology to see a needle in a haystack now, and that's what they do. So when they see something, when they see a needle, then they say, look, there it is. I told you all along. But you don't die from a needle in a haystack. You could have mercury, uranium, strontium, botulin, cyanide, and anything combined in 1 out of 1,000 T cells. You would not even notice it. You would only notice something that gets 30% of your T cells. Then you're in trouble. But whatever happens to one of them, no matter what is in there, from HIV to dynamite, it would not matter. You would never notice it. See? And that's what Dr. Fauci found, and that part he doesn't understand. He's not a quantitative thinker. He's more sort of a global thinker. Like, they're all very global now. They talk about pandemics, actually. That includes all sorts of continents at once. You know. So, in other words, what I'm saying here is that HIV meets every one of the criteria of a harmless passenger virus. At this time now, it is necessary to ask us the ultimate question about AIDS. Is AIDS, in fact, an infectious disease? The virus hypothesis didn't predict anything. The virus that we found there is not a causative virus, but a passenger virus. Now, is it true that AIDS is an infectious disease? In fact, proponents of the virus hypothesis, orthodox AIDS researchers, acknowledge that AIDS is not an orthodox infectious disease. I had an exchange with them in the Lancet last year when Jaap Goudsmit, he is one of the leading AIDS researchers in Amsterdam and also collaborating closely with the NIH. He's halfway there and halfway here. He acknowledged in the Lancet, he says, AIDS does not have the characteristics of an ordinary infectious disease. This view is incontrovertible. Then Eggers and Weyer, 2 epidemiologists and statisticians from Germany, published some papers at the International AIDS Conference in San Francisco 2 years. They said that the spread of AIDS does not behave like the spread of a normal infectious disease, but they had to simulate cofactors that cannot be identified with a known infectious agent to make the real data of AIDS distribution fit with an infectious agent. So they had to simulate some factor to reconcile that it stays only in men, only in homosexuals and IV drug users, and yet supposed to be an infectious disease. And likewise, Anderson and May, sort of the leading epidemiologists in Great Britain now, they're also writing for Science and Scientific American all the time. They had to make a different type of invention, similar kind of thing. They said the virus needs or follows, the disease follows some assortative scenarios. They have all this wonderful vocabulary. That means when you're a bad guy, the virus is bad to you. So if you don't use condoms and are promiscuous homosexual, God punishes you with a bad virus and you get dementia and diarrhea. But if you use a condom and are a good heterosexual, then the virus is good to you and you live for 10 or 20 years, like Bob Gallo said he himself. He wouldn't get sick because he's a paragon of integrity and virtue. Yeah. So the assortative scenario is that the virus senses what kind of people it infects. Yeah, that's what that means. That's what it means. That's really what it means. It's just a big word for that, for stating that same thing. If it infects a bad person, the virus is bad, and you get sick. Infects a good person, not much is going to happen. You have years to think about it and so on. You can work on your condoms and brush your needles, make them clean, and behave well, like Bob Gallo and other models of integrity. So now, with those conditions, we can see that even the AIDS orthodoxy acknowledges that AIDS is not a normal infectious disease. Let's have a look at the conventional criteria of an infectious disease, how well AIDS meets those criteria. Here they are. All infectious diseases, no exception known to me in the books of virology, are equally, or microbiology, are equally distributed between the sexes. There's no exception to this rule. But AIDS radically deviates from that. Not just a tiny bit, but from an epidemiological point of view, this is as radical as you can get. That's as day and night as you can possibly get. This has been 90% male in America and 86% male in Europe for 10 years now. And these are populations that add up together to 400 million. In those populations, AIDS has remained 90% male now for 10 years. Clearly totally incompatible with any known infectious disease, anything we have known so far. The causative microbe in an infectious disease, as we already discussed now, is abundant and active in target tissues, causing damage that now causes the disease. But in AIDS, despite enormous efforts, no common active microbe has ever been found. What is claimed to be found is HIV, but when it is found, it is by no means active. It is only detected as a latent virus in 1 out of 1,000 cells with a polymerase chain reaction, and as I said, even that isn't true in many cases. The reason why notorious AIDS research, for the notorious difficulties of leading AIDS researchers like Gallo and Robin Weiss in England in isolating the viruses. We had 3 years investigation where the viruses come from, and it turns out that Robin Weiss is the leading AIDS researcher in England, and Robert Gallo in this country, their viruses were the same as Robert Gallo's. If there had been abundant virus in AIDS patients, I'm not saying that they're the greatest virologists, but they're good enough to have isolated their own virus. They haven't because there's nothing there, or so little they couldn't get it. So the third criterion of an infectious disease is that infectious diseases typically follow soon after infection. Again, we covered that point from some other point of view. And prior to immunity. That's the time for the virus to strike, before the defense department moves in and slows them down. And the reason why that is going so fast is because microbes and viruses all replicate within hours, or at the very latest within days. That's their life cycle. All known bacteria replicate within 30 minutes or 37 degrees, and viruses within a couple of hours. There is no virus that takes that so-called slow virus. There are slow virologists, but there are no slow viruses. Viruses all replicate within 24 to 48 hours. They replicate just as fast as the cell does, because everything that viruses make is actually made by the cell. They use the equipment of the cell. They cannot put on their own timescale. They can only put in their own disk in the computer and say, write what I want to write. But they cannot determine the speed or the alphabet or how it's done. So AIDS then fails all criteria of a conventional infectious disease, not even one it meets. So it is very likely, therefore, that AIDS may not even be an infectious disease. Now, in the face of this problem that AIDS doesn't, the virus hypothesis doesn't produce any results, fails all criteria of the infectious disease, and HIV is a passenger virus, it is high time to come back to what we used to call the scientific method. That is, you observe a subject from all possible angles, make a hypothesis that makes predictable, testable predictions. You test these predictions experimentally and see whether you can come up with a better hypothesis. And if it is, then you make patents and royalties, and you become famous, and you become a television star, and you get a Nobel Prize, and you get mistresses and cocaine and everything you want. And you get to work at the NIH and have good lawyers. And if it doesn't work, then you have to come up with an alternative hypothesis. Before we do that, in a second, let's keep in mind briefly what we have to do when we want to come up with a good AIDS hypothesis. We have to keep in mind that AIDS cannot be explained as an immunodeficiency, as it is commonly done, because about 40%, I had this other slide here, of the American AIDS disease last year, it was 39%, have nothing to do with immunodeficiency. So anything that would create an immunodeficiency is good enough to explain the pneumonias and the candidas and the mycobacterial and the cytomegalo, toxo, and the herpes infections. These are microbial diseases. But it's not enough to explain the wasting, the Kaposi, the dementia, and lymphoma, which are not immunodeficiency diseases. So a good AIDS hypothesis would have to explain this as well as that. And they do not have a known common denominator at this point, at least not one that I would know of. A good AIDS hypothesis also has to account for the fact that we have two entirely different epidemics. And I'm saying not just a little bit, entirely different epidemics under the same name. The American-European epidemic and the African epidemic. The American-European epidemic epidemiologically is 90% male. The African epidemic is equally distributed between the sexes. As I already pointed out, this is like day and night in epidemiology. That is absolutely incompatible, the two. There's no way you can say this is just a few years ahead of this or something like that. They say this is ahead of this when you ask them about here, and then they say sometimes this is ahead of this, whatever it is. But for the 10 years we know it, they're totally incompatible. The same is true for where the AIDS patients come from. In Europe and America, virtually 97 to 90% of all AIDS patients come from so-called risk groups. They're either former IV drug users or current homosexuals, hemophiliacs. In Africa, they come from everywhere. There are no risk groups. If you look at the diseases clinically, again, the epidemics are very different. They fall within the same 30 disease framework, which is by now virtually everything short of breast cancer. But nevertheless, when you look at the distribution of these 30 diseases between the two epidemics, you'll see they're very different. 50% of the AIDS diseases in America and Europe are pneumonias, then candida, mycobacterial, Kaposi, dementia, and so on. But that's roughly in the order of frequency in America. But in Africa, it's fever, diarrhea, tuberculosis. Less than 1% Kaposi. Nobody ever diagnoses pneumonia there. So the diseases that are called AIDS in Africa are very different. I mean, not absolutely, but very different. So clinically and epidemiologically, Africa and Europe are totally different epidemics. If we want to find an explanation for all of this, we better have one that can explain why the epidemic in Africa is fundamentally different, clinically and epidemiologically, from the epidemic in Europe and in the United States. Now, within Europe and the United States, we have HIV-infected risk groups which have totally different annual risks of getting AIDS and have, in fact, group-specific diseases. The highest risk group is the transfusion recipient. The average American transfusion recipient is said to die within a year after being transfused with HIV. That means the latent period, the annual AIDS incidence is about 50% of them. Yeah. So in 2 years, half of them are dead within a year. What they don't tell you is the average American transfusion recipient without HIV is also, has also a mortality of 50% within a year. Exactly the same. Well, the reason is because your average American transfusion recipient is not a 19-year-old kid falling from a motorcycle, but a 77-year-old Paul Gann with a 5-fold bypass operation and a pneumonia. That's what the majority of the transfusion recipients are, and half of them simply die within a year after that transfusion because of other underlying diseases. But nevertheless, their diseases are significantly different. Also, the risk of getting, quote, dying from AIDS is very different from the rest, as I'll show you in a minute, and their diseases are. They always get only infectious diseases. They never get Kaposi sarcoma, the fun diseases, or dementia or something. They get pneumonia and opportunistic infections. The American babies, they have also a high incidence of annual AIDS when they're born with HIV, as they say, but they get dementia and bacterial infections. They're born to mothers who are intravenous drug users. Again, when you look at controls, mothers who have no HIV, the babies have the same diseases when the mother are drug users during pregnancies. Now, the intravenous drug users and the male homosexuals have a 5% annual risk of developing AIDS, but the homosexuals are virtually the exclusive tenants of Kaposi sarcoma. Kaposi sarcoma is almost never found in anybody but male homosexuals. Not in drug users, not in babies, not in transfusion recipients, and not in hemophiliacs. And remarkably, the hemophiliacs with HIV, as I already pointed out, they live now twice as long with HIV than they did before, have a lower annual risk of getting AIDS in America and in Germany, whatever these numbers are, pretty close anyway, than an IV drug user or homosexual who are born without a congenital deficiency. The hemophiliacs do better than those who have have no congenital deficiencies. And here's just for fun, the Africans, because so many are HIV positive there, I said 8 million according to the latest estimate, but the number of AIDS cases is less than in this country, have the lowest annual risk, because if you divide AIDS cases by the 8 million, you get only a 0.3% annual incidence of AIDS when you're antibody positive in Africa. So if you believe in the virus hypothesis, your best bet is if you're antibody positive now, go to Africa, and your odds of getting AIDS are 10 times lower just for moving there compared to this country. That's not a bad deal, you know? It doesn't cost that much. So here's what I propose as the alternative hypothesis. I postulate that AIDS in the US and in Europe is caused by the long-term consumption of recreational drugs, that is cocaine, heroin, poppers, amyl nitrate inhalants. I'll document it in a minute in a little more detail, and by ACT, above all by ACT. The remaining AIDS cases in America, the hemophiliacs, transfusion recipients, and other cases from non-risk groups, like the Kimberley Bergalicis or the Archer Ashes. Yes? All right, they reflect just the normal incidence of these diseases under a new name. And the African epidemic, I propose, is the consequence of malnutrition, parasitic infections, and poor sanitation. Diseases of poverty, as they always existed there, has nothing to do with the European and American epidemic. The European American epidemic are the clinical manifestation of the drug epidemic which started in America after the Vietnam War and spread into Europe very soon after. Now here's how we can document that roughly. There are statistical overlaps between drug use and AIDS, chronological as well as epidemiological. These numbers now do not come from Science or Nature or from the Lancet, because nobody wants to talk about drug use. That's only in America dealt with in the criminal courts, like homosexuality 30 years ago, with machine guns, U-boats, submarines, and B-52s, at budgets that are even bigger than for AIDS. Nobody talks about drugs as a health problem. They're only criminal stuff, good old criminal stuff. Now here's what you get from the Bureau of Justice Statistics when you write to them, and I'm not their greatest friend, but here they tell you they confiscated in 1980 500 kilograms cocaine, and they estimated at the time they confiscated about 10% of the good stuff. The remainder went up wherever they go up, the nose, the ass, the sleeves, of the American consumer. And in 1990, 10 years later, they confiscated 100,000 kilograms, or 100 tons of cocaine. Now it's even higher. And they still estimate that they confiscate only 10% of the good stuff. So roughly 1 million kilograms were consumed in America in 1990, a 200-fold increase in those 10 years. Amphetamines, which are used as ecstasy and for parties and for particular by gays, in discos and in bathhouses and all these things, They confiscated 2 million doses in 1980 and 100 million doses in 1990. For poppers, they don't keep any records because they're considered harmless, soft drugs, but there are some numbers available that in 1980, 250 million doses of poppers were consumed in the United States at the time when Boris Wellcome was still producing poppers also for the gay market and advertising in gay magazines. In 98 million Americans were using cocaine regularly, that is a couple of times a month or a week. And in 1992, 180,000 worldwide have been receiving AZT, as I said, the most toxic drug that has ever been prescribed for long-term consumption, HIV positive. In the world, about 75% of these from America. So now, how do these correlate with AIDS? As you possibly recall, we showed earlier this one slide. Here's the increase of AIDS, and here's what happened to HIV. Nothing with HIV, AIDS goes up. But here's cocaine, what I just told you, I plotted it on a curve. Cocaine parallels, the cocaine consumption parallels the increase of AIDS quite nicely. And also, cocaine-related hospital emergencies due to overdoses, they went up from a few hundred cases in 1980 to 80,000 cases in 1990. Again, data from the Bureau of Justice Statistics. Now, how do I account for the major risk groups now? A third of all American AIDS patients, that's about 80,000 in this country, and about a third of those in Europe, that's about 30,000 or 25,000 by now, 75,000 there altogether, are heterosexuals mostly who were intravenous drug users. They have been injecting drugs for 10 years. That's what they call euphemistically the latent period of the virus. The virus is indeed latent, but the host is not injecting these drugs for an average of 10 years. That is confirmed by the Centers of Disease Control in their HIV/AIDS surveillance reports. They say a third of them, or 85,000 roughly, of the American AIDS patients were intravenous drug users. Now, what about the homosexuals? They are the hardest ones to document. They are, as I submit to you now, users, long-term users of oral drugs, not injected drugs, but orally consumed drugs that are used mainly or partly at least as aphrodisiacs to facilitate anal intercourse, specifically nitrite inhalants. They were designed 100 years ago as vasodilators against angina and have their psychoactive effects, giving you a high, and also facilitated anal intercourse by relaxing the smooth muscles, have been detected only in the 60s accidentally and have since become the token of gay liberation, that drug. And now we have another rich source of AIDS patients to come, the 200,000 who get AZT. They will all be AIDS patients like Arthur Ashe and Rudolf Nureyev and Kimberly Vegalis. Those are all killed by AZT, by 1 or 2 years of AZT. That will be the richest source of AIDS patients in the future as long as we continue to prescribe AZT. Now, here is some data for the homosexuals, which is the hardest one to document. Just before the virus hypothesis was announced in 1984, the Centers for Disease Control still studied what was then called the lifestyle hypothesis. That is drug use, a euphemism for drug use on gays. Here are 170 gays with AIDS, and here's the drugs that they used. Self-reported by the CDC, Henry Jaffe, the director of HIV/AIDS now at the CDC. You can see 96% of these guys had self-reported. That was not verified, not tested, just self-reported. Nitrite inhalant, regular use, ethyl chloride inhalants, cocaine, amphetamines, phencyclidine, LSD, methaqualone, barbiturates, marijuana, and heroin. So these guys were walking pharmacies. But the reality was HIV, of course, did all the damage. This stuff cannot hurt you. This is just like Bircher Müsli or coffee, whatever your preference is. Yes. And now in 1987, a similar study also conducted by the CDC on a gay cohort in San Francisco, you can see the numbers haven't changed. And they shouldn't change because the medical orthodoxy tells the American consumer or the gays, don't worry about drugs. They don't say it this way. What they say is make sure you wear a condom and use a clean needle. We are not the police. We are no bigots. You can use your drugs. They don't hurt you. They are only, and they may be against the law, but they're not against your health. And they always blame me for saying, okay, when they follow you, they throw away their condoms. That may well be true. But when they follow them, they may throw away their old needles, but they pump through those needles the same old drugs that they get from certainly not a graduated microbiologist in his black BMW in Oakland or wherever he comes from. So that is their responsibility, and AZT is also their responsibility. Mine may be the condoms. So whenever both of us are on the last judgment day, I would have to argue with God about condoms, and they with AZT and recreational drugs. I think I have a better stand, but who knows? We'll see. And the best way of pointing out how it's perceived by the American public, what the medical orthodoxy is now doing by telling them use condoms and plain needles, is the joke. There were two drug users in New York, junkies, that shared a shot of cocaine. And the third one joins him and says, you guys are crazy, you're getting AIDS from that stuff. He said, no, we have nothing to worry about. We both wearing condoms and we have a clean needle. That's, that is the message of the medical orthodoxy now. General Koop, Anthony Fauci, they print it, it's on television, it's on the New York Times, everywhere. Drugs are harmless as long as your needle is clean and your condom is Michelin quality, whatever it is. So how do you prove that drugs actually do play a role in AIDS? There are two ways of proving it directly. Either you have to identify that in two groups, both of them are HIV positive, only those who are also using drugs are getting AIDS diseases, or you identify AIDS diseases in HIV-free persons. And of course, they have a way out of this one. They will call that idiopathic CD4 lymphocytopenia. But they haven't quite done it in all cases yet. But here are some examples where that has actually been done and published in the literature. Here are 65 IV drug users from New York who were introduced into some kind of a methadone program. And some chose to work in the methadone program or in the withdrawal program and gave it up, and others continued to use street drugs. Those who continue to use street drugs continue to lose 35% of their T cells per year. Those who stopped didn't lose any further T cells. Their T cell levels stabilized. There's a group from Zurich in Switzerland, pretty much the same, 300 IV drug users. Some continued, some stopped. Those who continued to use street drugs had 3 times as many AIDS-defining diseases per year than those who discontinued it. An interesting one from LA, there were 11 patients on AZT, and they were taken off AZT in favor of an experimental vaccine. 10 out of 11 of them recovered immunity, cellular immunity, within a week or two after being taken off AZT. Yes. So one of them did. Now, here are a couple of examples of cases who have exactly the same diseases with and without HIV. Again, IV drug users from New York, a paper published in Science in '88, pneumonia, endocarditis, and tuberculosis, all AIDS diseases now. Here you can see these guys, it's about 50 with HIV and about 50 without HIV. Exactly the same diseases in IV drug users with and without HIV. This is a paper on homosexuals Six of them were published in The Lancet, had all Kaposi sarcoma. Not one of them had was HIV positive. Again, IV drug users from Germany, Sweden, Amsterdam, all the same story. Here's a group from New York that break down the diseases: fever, weight loss, night sweats, diarrhea, mouth infections, 89 with HIV, 49 without. Here are babies, so-called AIDS babies from San Francisco, 9, all born to mothers who were injecting drugs during pregnancy. 9 of them had dementia and immunodeficiency, like bacterial infections, were HIV positive. 29, actually it's 39, were HIV negative, had exactly the same diseases. And in both cases, the mothers were drug users during pregnancy. 80% of the AIDS babies in America and Europe are born to mothers who were injecting drugs during pregnancy. So, do we have any evidence, contrary to what we get from the medical establishment now, that drugs are immunotoxic, or that drug use is toxic? Indeed, when you check the literature, there's a lot of it in the literature. Starting in 1909 in Paris, the first report on cocaine users, long-term cocaine users, there was a mild epidemic then in Europe when Freud and Sir Arthur Conan Doyle were using cocaine. then they observed the first cocaine victims, cocaine addicts who had had the same diseases that are called AIDS now: immunodeficiency, weight loss, fever, mouth infections, endocarditis, pneumonia, tuberculosis. All the good old AIDS diseases have been observed since 1909 in long-term recreational drug users. I'm not talking about one party on a weekend or so, or one party per month. These are serious long-term addicts. Nitrate inhalants, which are used by the gays, as I pointed out in the statistics, are the first mutagens that we ever understood how they work. They're mutagenic. They change the DNA sequence, and they're also one of the best-known carcinogens because they change the nucleic acid structure. They transform cells in tissue culture, and they cause cancer in animals. The Food and Drug Administration limits the concentration of nitrates to less than 10 parts per million. You cannot sell your lachs or your meat or your Polish sausage or German sausage with more than 10 parts per million nitrate per meat product. But the amount that is consumed as a recreational hit by gays in a gay bar is up to 1 milliliter per person per night, or even more. Those guys couldn't be sold on the meat market for at least 2 or 3 days under nitrate hydrochloride by the FDA. But if you point that out, that this may be toxic, you're immediately labeled, you're homophobe, you're bigot, you're fascist, you're communist, you're all those things. But when it goes to lux, that's all right. Everybody agrees. You can't sell that lux anymore. But your gay partner with a milliliter nitrate is fine. You can sell them anytime. As long as he wears a condom, of course. Yeah. That's all right, yeah. That's all right. You know, that's their human rights, you know. Don't tell them anything about it. So, and here about AZT. Well, AZT is a chain terminator of DNA synthesis, developed 30 years ago for one purpose only, to kill human cells. Well, there's a rationale to chemotherapy. The cancer is among the most persistently growing cell in the body. You try to get rid of it in the hope, by killing everything that's growing for a while, in the hope that the cancer dies first and the patient not yet, you know, and then it recovers. So that makes sense in the case of the cancer, but here we are applying it to people where 1 in 1,000 cells, you asked that question earlier about Fauci, even in those papers, that hasn't changed. Roughly 1 in 1,000 cells at the most is infected. So since AZT cannot tell an infected from an uninfected cell, for every infected cell that AZT is going to kill in the body, T cell or any other cell, it will have to kill 999 uninfected C cells. That is what you call a very poor pharmacological index. That's what's happening with AZT. It is really the equivalent of chasing bunnies with neutron bombs. Yeah, you get them, but you know the forest looks a little different. And look at the guys on AZT. Look at Arthur Ashe. Look at Rudolf Nureyev. Look at Kimberly Begalis. They ended up on wheelchairs. They looked like they came from Auschwitz. Well, 1 year of AZT is doing exactly that. It's killing the muscle cells. It's killing the bone marrow. It's killing the epithelial cells and killing the gut. All the fast-growing cells are going first. So these people need wheelchairs, blood transfusions, and intravenous feeding until they die finally from it. And that's, I mean, from a molecular point of view, molecular biology becomes extremely predictable because there is no life without DNA, at least none that I know of or ever heard of in anything, except, of course, maybe somatids. I don't know yet. We have to somatids and cloviruses. But most other things, certainly homosexuals have DNA, and hemophilia have, and Nureyev has, and Arthur Ashe has DNA. So here's how it works. AZT is an analog of thymidine. You know, all these nucleotides have 2 ends, a 5' and a 3' end. And with AZT, there's no 3' end. So when that thing is incorporated, instead of this, it's an analog, it looks to the DNA or to the enzymes in the cell exactly like this one. Then this looks the same, but it can't continue because there's no link. That's the end of the chain then. And when the chain is ended, the cell is ended. Every time that happens, the cell is dead. Or when you're lucky, it's mutated. You could get cancer if you're lucky. So those are the 2 options. That's all that AZT can do. And they always talk euphemistically about side effects. Yeah? There are no side effects. This drug has clearly no side effects. All it ever does is kill cells. It's no side effect. Here, I study AZT a little bit in the lab now because they say the toxicity is much lower than I think it really is. And we ordered it not from Boris Wellcome, because Boris Wellcome is not on good terms with me. So we ordered it from an old company, old biochemical company, Sigma it's called, in St. Louis. And they sent me 25 milligrams, which is 1/20th of the dose that is given to everybody who is antibody positive in this country every single day. And look what they tell me. A PhD in the laboratory is going to watch out for, is going to be warned by the toxicity of AZT with the skull and crossbones. That's a PhD student working with it, not to ingest it, just make sure that you don't get in contact with this or get splashed with it. This is accorded only to substances with the highest level of toxicity. I have in my whole laboratory maybe 2 or 3 bottles with that sign on it. When Boris Wellcome sells it, you'll see a nice girl or a boy on it on his mountain bike with their spandex, drinking Perrier, and then there's a line on it, putting life on your side. When Duesberg and his students buy a 20th of it, what these guys on their 10-speed mountain bikes take every single day, and take a 20th of it, we get a skull and a crossbones. Better watch out, babies. That's what they say. So that's, you can see some chemicals seem to have the same idea as Duesberg has, that AZT may not put all that much life on your side after all. So what I'm now proposing also is that the drug hypothesis resolves all the paradoxes that the virus hypothesis has created. And I just name a few here. One of them is, why is it that only men, for example, get AIDS, or 90% of the AIDS cases in America and Europe are males? Well, again, that cannot be learned from HIV infection, but when you study the epidemiology of drug use. The Bureau of Justice Statistics tells you that in America, and similar things has happened in Europe, that about 75% of the hard recreational drugs, the injected drugs, cocaine and heroin injected, is bought and sold and consumed by males. Only 20-25% by females. Females lead in the soft drugs, men lead in the hard drugs. And virtually all of the poppers, the nitrate inhalants, the ecstasy and these things that are used as aphrodisiacs are used by gays because heterosexuals don't need it, whereas gays are using it, or some gays. I should really emphasize qualify gays significantly. This is only true for a very small percentage of the gay population. Those who have hundreds of sexual contacts, they facilitate anal intercourse. That's why they use these drugs, in part. And whereas heterosexuals, the plumbing is designed that you don't need chemicals to have sex here. So that explains the 90% maleness of AIDS in America and Europe, where it's a drug disease, IV intravenous drugs or homosexual aphrodisiac drugs. The reason why AIDS is new is also readily explained by the drug epidemic. I'm not saying that any of these drugs is absolutely new, but the consumption, the dosage, the amount of drugs consumed in the United States is new. As I pointed out, in the case of cocaine, the consumption has gone up 200-fold, amphetamine 100-fold in the last 10 years. It's exactly like smoking and lung cancer. When the Navajos were smoking peace pipes, you didn't hear of lung cancer. But when we started smoking 2 or 3 packs a day, then all of a sudden lung cancer came up in the 30s or 40s and 50s. First in men, and when women picked up smoking, then now women have caught up with us, men, in smoking as well. That is the same here. AIDS is new because the drug use epidemic, the recreational drug epidemic is new. And AZT, of course, is even newer. That only started in '87. Those victims are coming in now. As I said, Ash, Begalis, and Nureyev are some of the most notorious AZT victims in my books. Certainly they died with AZT. Some people may argue it's all HIV, of course, but showing me no control. So how did all of this happen? Why did this go wrong in such an enlightened era where we know everything in science? Well, here we're dealing with 2 problems that I think explain the disaster or the fiasco in AIDS. One is the one success story that we actually have, and it's only one in medicine and biology, and that's the germ theory. The recognition that diseases can be caused by microbes and that they can be eliminated primarily by good nutrition, by keeping your immune system in good shape, by hygiene, and also a little bit by antibiotics and by drugs. So the elimination of infectious diseases with the germ theory, starting with Robert Koch and Louis Pasteur, printed an image of heroes into the minds of all medical students and biologists. I'm going to be the Robert Koch of breast cancer or the Louis Pasteur of tennis elbows. I'm making a vaccine against tennis elbows, it's gone, and I'm going to get a Nobel Prize, and I'm going to be Robert Gallo or Louis Pasteur all over again. That's what they're all dreaming of. We're all inclined to see every disease infectious. For 20 years, we have been chasing in the virus cancer programs for almost as much money as for AIDS now, viruses as causes of cancer. We come home empty-handed. Gallo was part of it, Baltimore was part of that group, Robin Weiss was, Duesberg was. We all virus hunters trying to blame cancer on viruses. Well, this mission failed completely. It wasn't as bad, not as costly as with AIDS and as avoidable as AIDS, but we mistook a non-infectious disease for an infectious disease because we know what to do with an infectious disease. And in fact, we are also conditioned in the Western world to believe that all bad things come from without, because we are created in God's image, and the bad things are either women originally and apples, and later it was, when the microbes were found, it was bacteria, and now it's viruses, slow viruses, what have you. It's never from within. But the problem is, people have also difficulties from within, and they are much harder to deal with. You have to look at the cell. Nobody wants to do that. So that bias has cost us dearly, and I give you a few examples that we always inclined to believe it's an infectious agent rather than a toxin or behavioral or a genetic problem. And then another real problem is that big funding and limited expertise are paralyzing research. When you make so much money, the ideology that you can buy every solution is not helpful when you don't know the cause. Once you know the cause, then money can do wonders. If you know how to get a man on the moon, with money you can get him there. Or if you know how to split the atom, you can build a bomb and nuke the Japanese. But if you don't know what cancer is, you can pour in as much money as you want. You get a big establishment that, in this case, insisted in viruses, or in AIDS, insisted in viruses being its cause and wants to keep those $4 billion and doesn't help with the solution. In fact, it now excludes any alternative views, as you can see in my example and quite a few others, I'm sure, who have the same complaints. They cannot get a hearing and cannot get any funding because they are a minority, and the other guys would lose their $4 billion. If you have so many bucks, you don't want to use them. There are so many commercial interested in, they would not let anybody else get even a cent. So here are the prices that we paid for these problems in the past. In the 20s, in the 10s and 20s, the US Department of Health, the precursor of the National Institute of Health, insisted that Pelaka, at the time, where 10,000 died in the South, was an infectious disease caused by poor hygiene, sexually transmitted, almost exactly like AIDS. Those farmers, the blacks in the South, were messy guys. You know, they didn't have showers, they didn't use condoms and all that stuff, and so they had Pelaka, a dirty disease. Now, Goldberger from New York, a pharmacist, came down, studied it, and he said it has nothing to do with the microbe, it's not an infectious disease, it's a nutritional disease. What he was observing is that these guys were all eating corn, whereas the doctors in the hospital treating them were still eating corn and chicken. And the farmers even didn't want chicken. They were so used to corn, they kept eating their corn until they died from it. And Goldberger finally prevailed 10 years later only to show that it's a vitamin deficiency, and out of it came the discovery of vitamin B. But for 10 years they insisted it's infectious, and 10,000 died needlessly. Well, Scrapie virus was given a Nobel Prize, Wisner and Kuro, to Carlton Gajdušek, the man who claimed to have discovered slow viruses. Well, that Nobel Prize, the man lives at the NIH, he's a friend of Carlos, was given in 1976-77. The viruses have not been found, the disease doesn't exist anymore, and now we are at so-called prions, some proteins that are presumably taking over the role for the slow viruses, and those proteins have just been shown to be normal cellular proteins. So the disease doesn't exist, the virus doesn't exist, the Nobel Prize still exists. But it's a precedent for slow viruses, that viruses could work over decades, and that has stuck because it was sealed with a Nobel Prize, and serves even now as a model for AIDS. You get infected today, and 10 years later you get diarrhea, you know, from the party you had today. Too bad. Anyway, so another example, in the wake of the virus cancer program, Burkitt lymphoma, a leukemia form, frequent in Africa, rare here, was blamed on Epstein-Barr virus. Now it is blamed on a chromosome abnormality. Cervical cancer in the US was blamed in the 70s on herpes virus. Here by Bernhard Reutzmann in Chicago was the leader in the 70s. In the 80s now it's a German chap, Zuhausen, he says papillomaviruses are the cause of cervical cancer. The same disease caused by different viruses, but in reality you find the same incidence of cervical cancer in papillomavirus positive as well as in negative women. There's no difference whatsoever. Now AIDS is the most recent mistake along these lines. We are blaming a drug disease, a retrovirus for a drug disease. And the one that is just coming up now is chronic fatigue syndrome. Now it's a yuppie women disease. They say those women are getting tired at home, vacuum cleaning. And Gallo and J. Levy, some leading retroviruses, are already claiming retroviruses as the cause of it. But my prediction is a shortage of cocaine. If they had cocaine, they wouldn't be tired. Thank you.
Is turning into. At our last board meeting, we decided to more formalize our education process, and so several committees got together, which I'll go over in a minute, basically to enhance the mission statement of the International Academy of Oral Medicine and Toxicology. And I thought that this would be very appropriate for those of you who are new to the Academy to take a look at. Just so you know where we are going with this, in the process of developing the education program, I have also submitted most of this information to the Academy of General Dentistry so that we could become a national sponsor through the Academy of General Dentistry. They will be reviewing our application on the 23rd of October, and hopefully by the 1st of November I should receive a response whether or not we were accepted. And if that does come about, we will be able, without separate applications to the Academy of General Dentistry, anywhere in this country, sponsor programs and have accreditation for members of that academy for fellowship and mastership credits. So what I thought we would do, and I have to tell you that these are not all of my ideas. Mike Ziff, Dave Reggiani, Rich Fisher, and other members, they were a great help in helping me develop these ideas. What we thought we would do is piggyback our education process on the back, on top of the Academy of General Dentistry. So when I got the application for the Academy of General Dentistry, I thought, gosh, I've got 80% of this done. What I did do, though, was I changed the terminology that we had talked about and used the same terminology as the Academy of General Dentistry. So when they received their application, as Jack Hall, who's very active in the Academy, found out, we kind of mimicked and mirrored exactly what they were doing. It's going to be very difficult for them to turn us down, I think. But you never know, okay? Next overhead. This is the program that the Academy, the way it is set up now. The education planning and approval is done through 5 committees. The meeting committee, which does general arrangements for regular IAOMT meetings like this one, and for other program sponsors. So if a program sponsor wants to hold a meeting, the meeting committee can help them with the general arrangements as far as giving them advice as to how to go about doing it. The education committee deals with the administration of the program for attendees and the faculty. The program committee would deal with the selection and approval of the program sponsor and the faculty. The program committee is made up of the 3 presidents, the president and 2 vice presidents. Rich Fisher has said that he would serve as program chairman, and even after his term in office is over, he'll continue until he decides to resign as the program chairman, so we'll have some kind of continuity. The education committee is made up of the past presidents. The Standards of Care Committee, I'm the chairman of the Standards of Care Committee, and the Fellowship Committee was demonstrated last night by our host at the dinner with Gary Strong. So as you can see, with the input of these 5 committees, we develop education planning and approval for regular regional meetings and the annual meeting that you're hearing today. Individually approved program sponsor meetings I'll go into in just a moment. The results would be IAOMT Fellowship and Mastership Program, and anyone who attends this that belongs to the Academy of General Dentistry will get credits for Fellowship and Mastership. Next one, Mike. This is the content of our education program, and I have to tell you that this will be reviewed by the Board of Directors. We have some time set aside for it tomorrow morning. It certainly is not finalized, but the skeleton is there. There's a lot of small details that still need to be ironed out. But it deals with the mission statement, which you saw, an explanation of the education program, a program sponsor, the presenter, the enrollees, the requisites for fellowship, prerequisites, and then being able to track the credits. Let's skip over to the program sponsor, Mike, and put up the application. I've developed an application for the program sponsor. This can be anyone who would like to put on a meeting under the auspices of the International Academy of Oral Medicine and Toxicology. You all received a blue flyer today, and if you open it up to the center of the blue flyer, you'll see a list at this present time of the faculty that the International Academy of Oral Medicine and Toxicology has. And what the sponsor would do is contact the program committee, and the program committee would send them this application. And there's a second page, which we'll get to in a moment, but you can see we're just asking for details. What the goal of the program is, are you personally responsible for the administration of the program? Flip to the next page, Mike. Okay. You got 2 of them there, Mike. Yeah. Does the program include documented research, clinical research, etc., and a list of the various presenters, the length of their presenters, their presentation, and the application, which will be the next one that'll be on, but not quite yet, and how many enrollees, etc., 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 and they would return it back to Dr. Fisher, and the program committee would review the application and see whether or not we would want to sponsor that program. Go to the next one now. This here is the presenter's application. Every one of the faculty members, when they're going to give a program, would have to submit this application. If they've already given the program, they can just put down that they previously had given the program, and the code, the course code that they had given would be put in here, and we would have all that information on the computer, so they wouldn't have to fill out the whole application. But you can see the things that we would need is where it's going to be held, etc., and they could return that with a date. We prefer at this point in time 6 months prior to the meeting, and so the program sponsor would put this date on here, fill in their name and address, and then the presenter could return it back to the program sponsor, or if he forgets to do that, return it back to the program chairman, Rich Fisher. With this system here, we'll be able to track all of the programs. And I'm going to skip over now with this slide on here, Mike, to how we would be doing the tracking. We've developed a 6-digit code to track all of our presentations. It's an alphanumeric code. The first letter, if you turn again to your page, you'll see that there's various topics. For instance, detoxification. The code is a D. For environmental, it's E. It's very simple. We just follow the first letter. There's been very little duplication of letters. The second code letter would be the number would be the difficulty of the course, a 1, 2, or 3, 1 being basic, 2 being intermediate, and 3 being advanced. The last 2 numbers in that code would be the actual course number that the presenter himself or herself puts down. So Mike Ziff, hey, dual personality. Mike Ziff has already sent me his codes, and so he's labeled some of them 101, 102, 202, etc. So that when he goes back, he'll always be able to go back and know what course it is, and of course we'll know what he's presenting. Along with that information, he has to send us a curriculum vitae and an outline. So let's say someone else comes in and says, hey, I'd like to present a course, and it's going to be toxicology. It's going to be basic toxicology. We then have an outline that we would request that individual to follow, so that all the information the Academy would like to have presented as basic toxicology, let's say in Mercury, would be presented. So we're trying to simplify the process in a way. And then the last two letters of the code are the initials of the presenter. So that instantaneously at any time when someone sends in their application that they had attended a course, we'd be able to tell exactly what they attended and what they got out of it. And when the program presenter says, here's what's going to be on, we would know what's going on. Go to the next slide, or the next one. Last one. Yeah, this is the last one. This is the registration form for anyone who would like to pursue fellowship and mastership in the Academy. There is a fee that I had put down on here. I don't know if that'll be the exact fee. That may change. And all it is saying is that you will register with us so that when your information starts coming in, we'll already have you in the computer database and we can handle it. The system right now, to some degree, is going to be dependent on the Academy of General Dentistry. And the reason is the Academy of General Dentistry has a triplicate form that you fill out in order to receive credits from them. And all we thought we would do is add our code number on the corner of that form. It would save us a lot of paperwork and a lot of time and money, and then a copy of that could be sent on to the program sponsor or to the education committee so that we can get that filed. And that's basically it. Does anybody have any questions briefly about that? Yes.
Other courses not put on by our academy for fellowship or mastership?
Any courses that would be put on would have to have the approval of our academy. That's the purpose of this, if we're going to approve it for fellowship and mastership. And in talking with Jack Hall, any of the other courses actually would have to be, I believe, IAOMT sponsored courses. That's the only way we'd be able to do it.
Sponsored or approved?
I don't know if it's or approved at this point in time. It's something we still have to clarify. We're still getting a few bugs ironed out of it. But basically, this is the outline of how it's going to be handled. Thank you.